Hello, it's Dr. Shelley, and today, like I promised, we are going to cover a lot. This is a maternity video. It will be located in the maternity playlist where 10 or 15 other videos similar to it are included. Maternity is hard. It is under the health promotion and maintenance category on your candidate report. If you failed health promotion and maintenance, it no doubt had to do with the fact that you don't know your maternity. Maternity is hard because it's different from every other discipline, because what's normal in maternity is abnormal in another discipline. For example, shortness of breath in the third trimester, normal in maternity, right? Urinary frequency, normal, in the third trimester and even the first, whereas that's a UTI symptom in someone else, okay? So back pain, normal. Sciatica, common. All of these things that are problems in other patients are kind of like normal in the pregnant woman. So we have to do a better job of making sure that our students understand maternity, because typically you get the smallest amount of education in the specialty subjects. And if you just look around the country with all these stupid ass fucked up laws about D&Cs when there's a heartbeat, when a patient's miscarrying and could die, you definitely can see that the general public don't know shit about maternity. We're hoping to change that with you. So let's carry on, shall we? Now, so today we're looking at fetal monitoring, including the non-stress test, what's known as antenatal surveillance, and your favorite, veal chop. You know you like veal chop. Yes, that is the fun mnemonic to teach you about variable decels, late decels, accelerations, decelerations, whatever. So this is going to be a lengthy video, so we're going to go ahead and get started. Now, many of you already have my material, so if you do, I want to show you some of the pages that we're going to be covering. We are in the maternity handout, which, as you know, is part of every self-study program if you are in the self-study program in my course, or if you're in my class, right? So let me show you. You have to dive deep into the actual packet to find some of the pages we're going to cover. We're going to talk about how to time the contractions. We're going to talk about, so you need that page. We're going to talk about the patient who is having decelerations, whether they're early or late decels. So that page will be used. We're going to talk about the non-stress test, non-reactive, non-stress, not good. And then, of course, we're going to continue with our antenatal surveillance at looking at a biophysical profile, which is simply the ultrasound, which you know is the thumbprint, I guess, of this video. Okay, me doing an ultrasound on my patients. I was blessed. I was one of 3 RNs in the entire country and world to learn how to do biophysical profiles on high-risk patients in our antenatal NST clinic. Yeah, at Metro. Love Metro. All right, so that's that. Now, real quick also, if you are someone who doesn't know about our special deal, you can get, just real quick, you can get your maternity, your growth and development, your pediatrics, with all 8 of the pink packets, your oh my God, your reduction of risk, which is the #1 area of failure, your management of care, which is 20% of your NCLEX, your infectious diseases, which is how you learn to make your own flashcards from the list inside of here. And of course, pharmacology, the 2024 medication categories, the psych meds packet, because psych meds are the #1 meds on the test, the alphabetical order pharmacology packet, and your EKGs. You can get all of those Everything is fine for 99. Usually just the 8 is 88, but we will throw in the 8 with the maternity, pediatrics, and growth and development because it is a focus of the NGN NCLEX. We can throw that in, all of that for fine for 99, not 9 for 99, because you're actually going to get 8 plus 3, which is 11 for 99. So, you know, here. Text 216-410-0936. I'm in Ohio, Eastern time. I don't care when you text because I'm not going to answer the phone for calls, but I do like you to text. So go for it. Now let's get started because we got a lot to do. Here we go. External fetal monitoring. We know that we use external fetal monitoring in both antepartal patients and intrapartal patients. You got to know those terms. If you were to look at UWorld questions, you'll see antepartal, you'll see intrapartum. Okay, antepartum means you're still pregnant and it's during your pregnancy. Typically, the antepartal time frame, the antepartum time frame when we're doing this monitoring is called antenatal surveillance. It is being done during a high-risk pregnancy. The high-risk examples that you kind of want to know include diabetes, hypertension, intrauterine growth restriction, multiple gestation, which just means twins, triplets, whatever, oligohydramnios, which means too little fluid, just like oliguria, oligohydramnios, oligo, too little, hydra, water, amnios, amniotic fluid. Oligohydramnios is too little fluid. You definitely need antenatal surveillance. Polyhydramnios, poly, too many. Poly, too many, hydra, water, amnio, amniotic fluid. Polyhydramnios, right? Polyhydramnios. So that is too much fluid. That will get you a ticket to my clinic for antenatal surveillance. Congenital heart defects of the baby. Once we know this baby has a congenital heart defect, we are absolutely going to be scheduling this woman for weekly antenatal testing, usually around 32 weeks, but it can start as early as 24 weeks in very few kids, but it can start that early. I remember I had an RH sensitization situation where the mother was RH negative and the baby definitely was having some problems because of it. So she did not get ROGAM with previous loss or whatever. And we did start monitoring that baby at 24 weeks. Now, average is 30, 32 weeks, maybe 28 for diabetics. But just understand, antenatal means you're still pregnant, you're not ready to have a baby yet, you're not in labor, okay? Another high-risk issue, and I remember this one distinctly, is any patient who lost a baby before. Inside of them, their baby died. Oh, they're signed up for antenatal surveillance, okay? Now, external fetal monitoring done in the antepartal period called antenatal surveillance done for high-risk pregnancies may include just a non-stress test or both a non-stress test and a biophysical profile. Now, we got to go back to the packet that I told you was part of your nice little special discount, and let's look at that non-stress test, shall we? Okay. Here you can see that it says non-stress, 3 negative in a row to interpret results of a non-stress test. So a non-reactive, non-stress is not good, okay? Now, that's huge because look what I wrote. Next to our high-risk pregnancy information, I wrote R for reactive is reassuring. So reactive non-stress test is reassuring. Well, what the hell does that mean? Well, how do I know it's reactive? Well, it's reactive because the fetal heart rate goes up by 15 beats. Yes, you have to know this. By 15 beats, and that acceleration lasts 15 seconds, and the non-stress test is done in 20 minutes. And as long as you have 2 episodes of acceleration during that time, you're reactive. So this is what I need you to remember. 15 by 15, 2, and 20. 15 by 15, 2, and 20. 15 beats of acceleration in the heart rate lasting 15 seconds, twice in 20 minutes. That's a reactive non-stress test. A non-reactive, non-stress is not good. Hope I made myself clear. Now, so that is the antepartum type of testing. Again, you are still pregnant, you're not in labor, you have a high-risk pregnancy for God knows how many different reasons. It could be diabetes, high blood pressure, intrauterine growth restriction, previous death, intrauterine. This is IUFD, intrauterine fetal demise, congenital heart defect or other defects in this child, maybe Down syndrome or some other defect in this precious child, okay? Now, if I made myself clear, I'm going to erase this because I'm going to use the board to actually draw some of the strips that you're going to need to know for your NCLEX. I don't know if you know, you don't just get adult EKGs, but you get maternity strips on your test, and they have been popular lately. Let's just say that, okay? So let's erase this because we talked about it. That was your antepartum. Let's erase this because we talked about antenatal surveillance. Let's erase the actual part about the antenatal surveillance. So we have more room on the actual board because we have a lot to cover, and I'm going to need to do some teaching real quick about a biophysical profile. Now, I described for you what an NST was. I need you to understand what a biophysical profile is. Biophysical profile. This biophysical profile is a 2-part test. It is not just an ultrasound, but it is an ultrasound with an NST with it. So I can't do a biophysical profile unless I do a non-stress test with it. So in your maternity packet, on the next page after NST is assessment test for fetal well-being, biophysical profile. And I don't know if you can see, but she's clearly having an ultrasound done while she's pregnant. And then if you look at the points, you can see they use letters A, B, C, D, and E, because there are 5 categories that you need 2 points in each. I'm gonna say that again. 5 categories. The 5 categories that you need 2 points in each so you can pass your weekly antenatal surveillance exam include fetal breathing. I know it might sound crazy, but babies breathe inside of you. Fetal movement, fetal tone, amniotic fluid volume, and the NST. Now, all of these are on here for you to see, so don't worry so much. As long as you have it, you see the fetal breathing, the fetal tone, the good movement, the amniotic fluid volume, and the non-stress test, which we already talked about. So what would happen in my high-risk antenatal clinic that I used to run with my other colleague at Metro is we would bring our patients back, we would put them on the NST. If all the NSTs were booked, we'd just take them in the ultrasound room and do the ultrasound portion of the biophysical profile. You get 2 points for each and every one of those categories. If you get a perfect score, it meant that you had a reactive NST and you got all the points for fetal breathing, fetal movement, fetal tone, and amniotic fluid volume. It's a total of 10 points. And 8 out of 10 is reassuring as well, as long as you didn't get the points off for the fluid, because fluid is the lifeline of the baby. Amniotic fluid must be there. So if you were full term and you didn't have a lot of fluid around the baby, and maybe that's what you missed your 2 points for, we might even deliver you for that. Now, you don't have to know anything more than a biophysical profile is used in high-risk pregnancies to assess the well-being of the fetus, and that there are 10 points possible, and an 8 out of 10 is reassuring, a 6 out of 10 is repeat tomorrow. Everything else is you probably need to be delivered. I hope that makes sense, okay? So that's your biophysical profile. Now, let's talk about the actual logistics of putting a monitor on the actual patient, because we did case studies this weekend in our toe-to-toe here in CHELLYS Nursing Review. Remember, we do case study boot camp, and that's not to be confused with the fact that I'm having 2 big, huge boot camps right here in Cleveland, Ohio. The first one is in May. The second one is in July. We call it a spring fling in May and a summer sizzler in July. Baby. So if you're interested in that, just text me boot camp. I'll give you information. But the bottom line is we have our case study boot camp every single week anyway. So students come in this classroom, and this past weekend, we did some maternity. And what I did was I gave them a baby that the patient was 11 weeks and she was coming in bleeding. And it was every single student nearly that said, put her on the monitor. No. An 11-week baby monitored? No. So that's what we're talking about today, okay? When we put the external fetal monitor on a baby, we don't put the monitor on a baby until they're in the 3rd trimester. So you gotta kind of be 24 weeks and up to qualify to be on a monitor, because there's no way to monitor you before that. Okay, that you might wanna know. The 2 parts of the monitor that, if you've had children, you may even remember, the 2 parts of this monitor includes an ultrasound, and don't let that fool you. That's not the one where you see the baby on the whole screen like a television. No, the ultrasound part of the monitor is like a Doppler. It's the part that you put over the patient's belly where the fetus's back is, because you do your Leopold's maneuver to find out where's this baby laying. And once you find that baby's back, you put that ultrasound right over the baby's back, usually below the belly button of the patient, to get a really good hearing audibility of the heart rate. You can get the fetal heart rate using this ultrasound. Sometimes it's called a Doppler, sometimes it's called a transducer, by doing Leopold's and finding the heart rate is strongest over the baby's back. So The normal heart rate for this fetus is 110 to 160. Some sources say 120 to 160 when the baby's out of mommy, but while they're in mommy, it's 110 to 160, okay? Now, the TOCO, oh my God, is that important? The word TOCO actually means contraction. So the TOCO part of the monitor is put on the woman's belly to monitor for contractions. Now you got to be careful with this one on the test. It's not going to tell us how strong her contractions are. No, it's not, because it's external. It will tell us how far apart are they and how long do they last. Now, when I said how far apart are they, I hope your mind went to frequency. And when I said how long do they last, I hope you thought about duration, because that is the only thing that the TOCO or contraction monitor can tell you. Duration and frequency, but not strength. So essentially, it's helping you time the contractions. And yes, you care about timing those contractions, because in order to time a contraction, you've got to look at the beginning of one contraction to the beginning of the next contraction. And get this, they can't be too close together. So if you have contractions more frequently than every 2 minutes, that's too close together. And if they're too close together, the word that might be used on your test is called tachysystole. It means that this patient's uterus is doing too much. Maybe it's because we put Pitocin on her, maybe not. Maybe she's doing it on her own. But this tachysystole means that this is a hypertonic, too much going on uterus, okay? It's just too much. You must have 60 seconds relaxation between contractions for this to give the baby a time to recover. So if, for example, said a different way, you have more than 5 contractions in 10 minutes, you have tachysystole. And we're going to talk about that down here when we tell you if the baby doesn't like it, you got to do some things, okay? So I hope that makes sense. Again, ultrasound, TOCO. Ultrasound is for fetal heart rate. TOCO is to monitor the duration and frequency of the contractions. So there you go. Now, the other type of monitoring is internal monitoring. Yeah, internal monitoring. So what did you find out so far? You found out that you can use an external monitor for antepartum and intrapartum. You found out that you can use the external monitoring on high-risk pregnancies. You found out that you can use this when the patient is in labor. Now we're going to internal fetal monitors, and there is a contraindication here. You have this is the only kind of monitor, or I should say this monitor can only be used in intrapartum. So it's only for women who are in labor. You can't use internal monitoring for a high-risk pregnancy and she's not near term and in labor. That's crazy. So internal fetal monitoring is only for intrapartum monitoring or during labor. Now, when you look at intrapartum monitoring, it's extremely invasive. OMG, like seriously invasive, like her water's got to be broken. See this? Patient's water must be broken. What is that called? SROM, S-R-O-M, spontaneous rupture of membranes, which is her water broke on her own. Or AROM, artificial rupture of membranes, which is done with this thing that looks like a crochet hook by the provider, not the nurse. and we call it snag the bag because it truly is like a crochet hook, and it doesn't hurt mommy or baby to pop the bag open, but that's what we're using with the technique. That procedure, if you will, is called an artificial rupture of membranes. This patient's water must be broke. You kind of had to know that. The patient's water must be broken. This is called spontaneous rupture of membranes or artificial rupture of membranes, okay? Now, newsflash, yeah, you probably know there's some contraindications to you thinking you're gonna put a monitor inside my body. Yeah, let's look at it. First of all, there's no way in hell you are putting an internal monitor inside my body after my water has been broken if I have HIV. That's a contraindication. If I have active herpes lesions, active, right now I'm having active herpes lesions, you're not putting a freaking monitor in my body. If I have hepatitis, come on, you're not putting a monitor in my body. Hello, we're gonna give this baby all of these infections. As it is, once the water breaks, you are at risk for infection anyway. You throw pieces and parts inside of me and we're gonna have a problem if we're not careful. Now, that's important. There are two parts, just like there were two parts to the external fetal monitor, the ultrasound and the toco. There are two parts to the internal fetal monitor. The first is the fetal scalp electrode. It's a little wire that literally slips underneath the scalp, so it's invasive. It's piercing that child, that fetus's scalp, and it's clinging to the tissue that it's pierced to monitor this baby. So we do need the baby to be head down. We also need, and I'm being real with you because I've been doing OB for 30 some odd years, and this is my forte. This is what I did all my life. I came out of nursing school and went straight to OB. I have seen providers just routinely, including nurses, just routinely slap a scalp electrode on the baby's head because they don't feel like keeping up with the monitor on the patient's belly. So women out there, nurses, women, nurses, whoever you are, if you have daughters, cousins, sisters, make sure that you're right there with them if you can be, if they allow it, so that you're making sure that this woman is just not being done any old kind of way because it's convenient. This is invasive. You're piercing my kid's scalp. I'd prefer you not to do that without a rationale. Now, there's plenty of excellent rationales. In fact, I had a patient who was 518 pounds, and I told her during the prenatal period, sweetheart, I'm going to be honest with you. I prepared her in advance. Sweetheart, I'm going to be very honest with you. As your nurse midwife, I am absolutely going to have to use internal monitoring to follow your child inside of you and your contraction pattern, because your belly is not going to be very reliable because you have a lot of fluff in there. I said it kind and lovingly without offending her. She got it. She knows. I mean, you know, this is what it is. So this was a realistic reason for why I would want to do internal monitors. But just because you lazy as fuck and don't want to get up and fix the monitor when it comes off, nah, hell nah. That's not a reason. Okay? All right, so you got it. No HIV, no herpes, no hepatitis. This is a contraindication to putting a scalp electrode or the second type of monitor that takes the place of the toco. So if I had a patient and I had the external monitor on them, and for whatever reason I've got to put internals in now, these would come off and she would have nothing but internals. And where that toco for the contraction monitor was, that would now be replaced by something called an intrauterine pressure catheter, or IUPC. So I hope that that helps a lot, okay? So there you go. You've got the IUPC, the fetal scalp electrode, the water must be broken. You have some contraindications. And here's our deal. The IUPC, that is the only way to monitor the strength of a contraction. You cannot do it with an external catheter. You can't do, with an external toco. You can't do the strength of the contraction with that. You must only use an IUPC. You can only use an IUPC if you need the strength. That's important when you have a patient with a previous C-section. That's very important, okay? So that's that. Now we're gonna do part 2, and I shall return. Deuces with veal chop.